Hello friends, I'm Pradeep here and we shall discuss about the new topic, that is peripheral nerve injuries. Peripheral nerves is unlike cranial nerves which comes directly out of the brain through the foraminers and innervate the facial structures. Whereas the peripheral nerves, they come out through the spinal cord to innervate the other organs, limbs, etc. So moving on to the peripheral nerve anatomy. So if you look at this image, so this is a structure of a neuron. Neuron is nothing but the basic functional unit of a nerve. It has a head that is consisting of nucleus, that is called cell body, and the nerve fiber that is running along the entire course, that is called axons. So this will be present in the spinal cord. This is what the peripheral nerve. So this peripheral nerves, if you look at the entire classical anatomy, so you see this peripheral nerve has a axon. So this axon can be either myelinated or unmyelinated. This myelinated axons are surrounded by multilaminated, like this. This is called multilaminated myelin sheath. And these axons are always supported by the Schwann cells. These are called Schwann cells. So in unmyelinated axons, there won't be any myelin sheath and they will be surrounded by just a Schwann cell covering. This entire axon is called the nerve fiber, which is surrounded by a endoneurium, by a sheath called endoneurium. There is a group of endoneurions. They are collectively called as nerve fascicles. This group of nerve fibers are collectively called as nerve fascicles, which in turn is surrounded by a membrane called perineurium. This nerve fascicles can be a group of either a motor neuron or can be a group of either a sensory neurons. So suppose for example, if you take a facial nerve, or there is a cranial nerve, sorry, if you take a median nerve, it has both motor and sensory functions. Like this fascicle can be a motor unit, this fascicle can be a sensory unit. So all these fascicles along with connective tissue like fat and blood vessels. These blood vessels are nothing but artery and vein. These are called vasa nervosum. As they are supplying the nerve, they are called vasa nervosum. All these are collectively covered by or enclosed in a sheath that is called epineurium. So to describe this in better manner, epineurium is the outermost covering of the nerve. The nerve fascicles are covered by perineurium and the nerve fiber is covered by the endoneurium. So with this clarity in anatomy, we will move on to peripheral nerve injuries. The common causes of peripheral nerve injuries can be, most common will be majority traumatic, either an external trauma or a trauma inflicted through surgeries. Like when you're operating on any soft tissue tumors, or when you're operating on any other surgeries where the nerve is in very close proximity, you can injure. So surgical trauma is one important cause. Example, best example is parotidectomy, but the thing is its facial nerve is a cranial nerve. So then thyroidectomy, vega rectal nerve is also a part of a branch of a cranial nerve. For example, you take a varicose vein surgery where we do saphenous vein stripping. Saphenous nerve will be in close proximity to the vein, that will also get injured during saphenous vein stripping. So these are the examples for surgical trauma. And this traumatic wound can either be a open trauma, cut wounds, or any blunt trauma that can cause compression neuropathy, etc. And inflammatory conditions like leprosy, herpes, all these can cause. Even a malignancy arising from the nerve, for example, a schwannoma can occur in any peripheral nerves, peripheral nerve sheath tumor, that is called schwannomas. All these can also cause a nerve injury in any form of nerve injury. And these are systemic causes like poisoning, lead and arsenic poisoning, alcohol, diabetes, and vitamin B1, that is called thiamine deficiency. All these are common causes, but most important thing we are worried about is the traumatic and compressive neuropathy and surgical traumas. Surgical traumas can be prevented. Traumatic and compression neuropathy can be treated. So what happens after the injury has happened to the nerve? So generally there are several classifications and degrees of nerve injuries which we will discuss in the future slides. But what really happens? So this is the nerve fire as we described earlier, and this is the site of injury that has happened. So in this case we take this the axon has been cut, axon axon has been cut, or the entire nerve has been transected. We take this scenario. So what happens proximally? This axons will retract here, and over a period of 9 to 10 days the proximal axons will form sprouts of multiple axons. These are called regenerating axonal sprouts. What happens distally? The entire axons and the entire nerve fiber distal to the site of injury will undergo till the end plate. Here will be the muscle, because nerves will be finally innervating the muscle or the skin. It's going to innervate muscle if it's going to be a motor nerve. It's going to innervate the skin if it's going to be a sensory nerve. So the entire thing distal through the site of injury, all those axons, myelin sheath, supporting nerve cells, Schwann cells, all will undergo inflammatory reaction, and they will be, when there is any inflammatory reaction, neutrophils and macrophages take in part, and the macrophage will phagocytose, means it will eat all the dead cells, dead nerve cells, and this process is called Wallerian degeneration. So the distal part of the nerve will undergo a process of phagocytosis of all the dead nerve cells by the macrophages. That process is called Wallerian degeneration till the site of innervation, that is the muscle end plate. And due to the inflammation there will be there will be lot of other cells that will produce some substances called neurotrophic growth factors. So what these growth factors? This growth factor will stimulate the sprouting axons to to find its way to the end plate, that is called the muscle. So this sprouting axons from the end, and they will form, regenerate, and finally innervate the muscle or the target it has to innervate. So this neurotrophic factors will allow the axons to go in the pathway as desired. This concept is called neurotrophism. This concept is called neurotrophism. So the process of destruction is called Wallerian degeneration. The process of reformation is called neurotrophism. With this, we move on to the nerve injury classification, that is the based on the degree of injury. Seddon is the first person who described the nerve injury classification. He described the nerve injury into three grades or three types. Number one is going to be neuropraxia. Neuropraxia is nothing but a temporary weakness. It is caused due to the disruption of the myelin sheath. Neuropraxia is nothing but disruption of the myelin sheath. So what happened? Only the myelin sheath has to seal. Rest the nerve is not disturbed. So there is no need for any regeneration or recovery time. It will be a complete recovery. So it's nothing but a temporary conduction block. Neuropraxia is nothing but a temporary conduction block, and it takes 3 weeks to completely recover. That means uh, 3 weeks to 12 weeks, 1.5 to 3 weeks to 12 weeks, up to 3 months it will take for complete recovery. The second type is called axontemesis. Axontemesis is nothing but the axons are divided. So as we discussed earlier, the part of the nerve that is distal to the site of the injury will undergo Wallerian degeneration, and the proximal end will cause sprouting of axons. So this proximal end will cause sprouting of axons, and with the help of neurotropic factors, finally the nerve will be formed and it will reach the muscle end plate. So here also the recovery is complete, but it will take longer time. The third one is called neurotemesis. Neurotemesis is nothing but complete transection of the nerve. So the nerve has been completely divided. So here the recovery is not possible unless surgery is done. Even then the recovery won't be complete. So surgery is the treatment. For axontemesis and neuropraxia, we generally wait for a period of 3 months before doing any surgical procedure to treat the cause. So we will discuss in future slides about how to diagnose the degree of nerve injury and how to treat the nerve injuries. So number one is going to be the Seddon's classification, and there is another classification, interesting classification, which will help in the treatment decision is given by Sunderland in 1951. So we know the 5 layers of the nerve sheath. This is going to be the axon. The immediate covering is the myelin sheath. Axon with myelin sheath is covered by the epineurium, which in turn is covered by the perineurium, and final component is covered by the epineurium. So axons with myelin sheath is covered by endoneurium. Sorry, it's endoneurium, perineurium, and epineurium. So we discussed earlier neuropraxia, axontemesis, and neurotemesis. So here Sunderland has classified into 5 degrees. First degree is neuropraxia as by Seddon's. That means this is a myelin sheath alone has been, there is a defect in the myelin sheath. Axontemesis is similar to Seddon's, that is second degree, wherein the axons alone got disrupted, but the endoneurium, perineurium, and epineurium were intact. In these two, first and second degree, the recovery is complete. Whereas with the third degree, here see the endoneurium has been disrupted. Only the perineurium and epineurium is intact. So here endoneurium also gone. And in fourth degree, perineurium, see the blue tinge, the perineurium also got disrupted. And fifth degree, even the epineurium got disrupted. So the fifth degree is equivalent to neurotemesis as per Seddon's. Third and fourth degree, there will be slight recovery possible, right? But it's not complete, because what happens when the regenerating nerve sprouts from the proximal end, it cannot align always. So what happens, they form a neuroma. Neuroma is nothing but the proximal regenerating axonal sprouts that mix with scar tissue to form a conduction block like structure, that is called a neuroma. Whenever a neuroma has formed, the nerve is unlikely to have a complete recovery. It's nothing but a scar tissue formation between the regenerating axonal sprouts and the injured nerve sheaths. And the third classification is given by McKinnon. He included the sixth variety, that is going to be mixed nerve injury. Sixth variety is going to be mixed nerve injury. And to evaluate, there is a clinical sign to evaluate the sign of nerve injury recovery, that is going to be called a Tinel sign. Tinel sign is nothing but you just have to tap along the course of the nerve. So, supposing this is the nerve, so my hand, this is going to be the nerve. So the nerve runs from here. So it has been cut here. If I tap on distal to the nerve, I can feel pins and needles at the end plate of the where the nerve is innervating. So that means the nerve is undergoing regeneration. So Tinel sign is nothing but tapping along the course of the nerve causes pins and needle sensation or hyperesthesia. So pins and needle sensation. This is a positive sign. Like when the Tinel sign is present, the nerve is very likely to undergo a recovery. That is a positive sign for us. What if without any stimulus there occurs a sensation of hyperesthesia? Hyperesthesia is nothing but hyperesthesia means increased sensory perception. That means it can mostly described as a increased pain, also termed as hyperalgesia. So this hyperesthesia is mostly common with incomplete sensory nerval injury. When the nerve injury is incomplete, so there will be increased degree of sensation that is perceived by the brain. So this is called causalgia. So causalgia is also called as hyperesthesia after an incomplete nerve injury, that is called causalgia. This is an indication for surgery. So let's move on to the clinical features of the peripheral nerve injuries, which we already discussed. That is a causalgia due to sensory disturbances, and sensory disturbances can be causalgia or paresthesia. Paresthesia means no sensation. Hyperesthesia means causalgia. Motor, there can be weakness, paralysis, weakness or paralysis can happen. On autonomic disturbances, there can be skin thickening, skin dryness, hair fall, that skin hair loss, everything can happen. Nails can be brittle along the course of the nerve, right? These are the common clinical features. How to evaluate the nerve injury? You should know the mode of injury, whether it is a blunt trauma or a penetrating trauma. Penetrating trauma if it's a gunshot, complex trauma, or a sharp incised tidy wound. Tidy wounds generally require repair immediately if it's complete. Okay, and time since injury, like most of the nerve injuries, most of the complete transaction of the nerve injury should be repaired within 3 days, mostly to be repaired within 3 days of trauma, that is 72 hours. Only if complete. So if incomplete, we can always have a always wait for 3 months for nerve recovery to occur. That too, which holds good only for blunt trauma or a compression neuropathies, not for cut wounds. Cut wounds, lacerated wounds always require, that means for example open wounds or open trauma will always require exploration, right? And degree of neurological deficit, and finally investigations to rule out other injuries before treating this, before treating this condition. And these two are called electrodiagnostic studies. Electrodiagnostic studies, one is nerve conduction study and electromyographic study. So nerve conduction study will help us to find out the conduction of the signal or the impulse to the distant end plate, and also the velocity of impulse everything can be studied. And the next thing is going to be electromyography, which will which will find out whether the distal end organ, that is the muscle, showing any uh, possibility of recovery, any possibility of actions through the when the nerve is stimulated. So this is called electromyography. So nerve conduction study is used to test the nerve, and electromyography is used to test the muscle, whether stimulating or repairing the nerve will be of any beneficial. So now let's move on to the treatment aspect. Like as I told already, that blunt trauma, the patient with a nerve injury sustained due to blunt trauma can wait, and we shall do serial electrodiagnostic studies, electrophysiological diagnostic studies over a period of 6 weeks and 12 weeks, and then we shall decide. What is the optimal time to do electrophysiological studies, the nerve conduction study or EMG? The optimal time is 3 weeks to 4 weeks, because it takes the axonal degeneration to complete within 12 days. That means the Valerian degeneration occurs for 12 days, and the axonal regeneration will be finally complete at the end of 3 or 4 weeks. The axonal regeneration rate is regeneration rate is 2 millimeter per day. It occurs at a rate of 2 millimeter per day. For in a transecting injury like a penetrating injury, immediate repair is mandatory, right? So what are the principles of nerve repair, like a surgical repair? So we should have a very good light and very good exposure. Like we need to make a wider incision or a longer incision to identify both the proximal and the distal ends of the nerve, and it should be a bloodless field so that it can have a better delineation of the vital structures, and good magnification using microscope or loops. Like people, plastic surgeons will be using microscope and loops to identify, to have a very good magnification of around 4 times to 10 times magnification, which will help in delineating the sheaths of the nerves, thereby they can achieve perfect anastomosis. So these can be possible with the help of microsurgical instruments and micro sutures like 80, 90, 10, etc. We will discuss about the sutures and the suture threads and the zeros in the in one of the videos. And tension free anastomosis is the dictum for all kind of anastomosis, like be it a vascular anastomosis, nerve anastomosis, or a bowel anastomosis. Tension free anastomosis is the rule, and less amount of sutures should be used to achieve this anastomosis, because more the amount of sutures, more the chances of foreign body reaction and scar formation. So to prevent that, less amount of sutures is needed to achieve the perfect anastomosis. When the distance between the two nerves, when the distance, this is the cut end of the nerve, this is the another cut end of the nerve, if the distance between the two nerves is less than 2 centimeter, so you can directly bring this nerve together and anastomose like this. Anastomosis means the technique of joining the nerves, or technique of joining the two structures together, that is called anastomosis. Anastomosis, bringing two structures together, two hollow structures or two structures together, two vital structures. Example bowel, example vessels, vein, artery, nerve, etc. All these are, when they are brought together or stitched together to establish the continuity, that is called anastomosis. When the gap is less than 2 centimeter, you can do a direct nerve repair. So beyond 2 centimeter, what will happen? They cannot be brought together without undue tension. Tension will occur. So in such situation, you can substitute that gap with the help of another nerve, that is called nerve graft, right? So for a facial nerve, we generally use greater auricular nerve and sural nerve. So nerve graft, we use autograft. Autograft means you are taking the nerve from the same person. Allograft is taking the nerve from the different person but same species. right? Xenograft is taking the something from taking the nerve or structure or organ or tissue from other species like pig, etc. So allograft is same species, autograft is same person. That means the patient himself. So the commonly used nerve grafts, usually we use sural nerve, greater auricular nerve, and the forearm cutaneous nerve, that is brachial and antebrachial cutaneous nerve. So these are the nerves we commonly use for the purpose of nerve grafting. Nerve transfer is nothing but when the proximal end of injury is not able to recover. So in such cases, the nerve from other area will be directed to innervate the target area. So those are called nerve transfers. These are way beyond our level. So better we stick with when to do nerve repair within 2 centimeter. More than 2 centimeter, we substitute with the another nerve that is called a nerve graft, right? So with this, the treatment of nerve repair has been complete. So these are the common peripheral nerve injuries and the deformities, like brachial plexus injury. When the injury occurs to C5 and C6 root, it causes Erb's paralysis. When it occurs in C8 or T1 root, it is called Klumpke's paralysis. Median nerve injury causes ape thumb. Ulnar nerve injury causes clawing. Radial nerve injury causes wrist drop. Common peroneal nerve injury causes foot drop. Bell's nerve injury causes swinging of scapula. So we will discuss about these brachial plexus, median ulnar, peroneal nerves in a separate video, right? So with this we shall discuss with some MCQs. So the first MCQ is the process of phagocytosis of Schwann cells and the injured axons and myocytes distal to the site of nerve injury is termed Wallerian degeneration. Right? Neurotrophism is nothing but the process of regenerating axonal sprouts to be directed towards the target innervation, that is muscle, that is called neurotrophism. Neurotomesis is nothing but division. Demyelination means just disruption of the myelin. Which of the following is intact in third degree nerve injury? Third degree nerve injury is nothing but first degree is neuropraxia, second degree is axontomesis. So axonotomesis, what will happen? Only the axons are disrupted. Third degree is along with the axons, endoneurium also get disrupted. So myelin sheath disrupted, endoneurium disrupted, axon is disrupted. Epineurium is outermost covering. Epineurium will be disrupted only in neurotomesis, not in other nerve injuries. Then, as I already discussed, what is the right time to do electrophysiological diagnostic test in a patient with nerve injury? Ideal is 3 to 4 weeks. Which of the following will not have Tinel sign 3 weeks post injury? Because 3 weeks is the time required for complete regeneration and complete Wallerian degeneration as well as regeneration. So Tinel sign is a positive sign wherein we tap along the course of nerve from distal to proximal. When there is pins and needle sensation along the course of the nerve, that means the nerve shows some recovery. So neurotomesis is complete disruption of the nerve. This will not have a Tinel sign, whereas axontomesis, neuropraxia, third degree injuries, all these will have Tinel sign. What is the ideal management for patient with clean cut injury to the median nerve following attempt to suicide with knife? Clean cut injury, that means cut injury has happened, that is an open injury. Clean, tidy, direct nerve repair is the option. If it's going to be a lacerated wound caused by a rusty knife or some any gunshot wound wherein you cannot bring the two nerves together, in such cases you can repair the nerve later. Nerve transfer is not at all required. Grafting also is not at all required. Just a clean cut wound is nothing but there is no loss of any nerve. If there is associated loss of nerve tissue, when the gap is more than 2 centimeter, we shall think of grafting. But in a clean cut, just approximation is achievable and it is the treatment option. So with this we have completed the peripheral nerve injury, the causes, the grade of injury, the classification of injury, how to evaluate, what are those signs and symptoms, what is the treatment option, how to treat, and we finally summed it up with the discussion of MCQs. In the next video, we will discuss about those specific nerve injuries like brachial plexus, median and ulnar, the pathophysiology behind those deformity and the treatment options. Right? Thank you.